Hello, everyone, and welcome to the 2022 Head and Neck Cancer Survivorship Symposium, developed by the Head and Neck Cancer Center Alliance and American Head and Neck Society. Our session is Nutrition, Swallowing, and Feeding Tube Challenges. I am Holly McMillan, a senior speech-language pathologist and certified lymphedema therapist at the University of Texas at MD Anderson. I want to thank our medical panelists, Barbara Ebersole and Debra Ruzensky, as well as our survival panelist, Mike Metzler, for presenting on this session topic today. Questions are welcomed either by chat or through the Q&A box, which we will review at the end of the presentation. To begin, I'd like to provide brief introductions of our co-presenters. Our first panelist is Mike Metzler, who is a retired professor at Georgia State University. He was diagnosed at the age of 57 with a stage 4 mucoepidermoidal tongue cancer. He completed 36 radiation treatments and 3 rounds of chemotherapy. Radiation and chemo cured his cancer but left him with serious and permanent side effects. He is an ambassador for the Head and Neck Cancer Alliance and is also the author of My 2 Journeys in the Cancer World, Team Mike versus the Prairie Dogs. Please welcome Mike Metzler.
Holly, thank you for that introduction, and thanks to the Head and Neck Cancer Alliance for allowing me to participate in this year's symposium, and thank all of you for attending today. Next slide, please. What I'm going to do is tell you my history with feeding tubes, my 2 journeys, first as a cancer patient being treated, and second as a cancer survivor. I had my first PEG tube inserted in March of 2009, just after I started my radiation and chemo treatments. That stayed in until August of that year, when I was able to eat gradually on my own and sustain my caloric and nutritional needs. In May of 2014, due to my osteoradionephrosis, I had a left mandible resection, and I left from that with the first nasal tube, which stayed in for about a month and a half. That maintained until June of 2015, when due to some complications from the earlier procedure, I needed a follow-up on the resection. I had a second nasal tube inserted for a short period of time. In July of 2015, it was apparent that I was not able to maintain my oral nutritional needs. And so in July of that year, after 2 badly failed barium swallow tests, I had a second PEG tube inserted, and that stayed in until the end of that year. Next slide, please. This is what I did, and this is what I learned each time I had one or the other type of PEG tube inserted. I got angry at first every time. I could not understand why I needed to have these things, and my reaction was, quite honestly, to be very angry. So I soon realized that the feeding tube was going to keep me alive. In the end, each of them was a good thing. What I also learned was not to ask, how long will I need each of these tubes? What I learned to ask is, what do I need to be able to do to be able to have this tube taken out safely? So in the meantime, I did my swallowing swallowing exercises, physical therapy, and stretching exercises every day. I learned to recognize small steps in the right direction and to build on those. Mainly what I tried to do is not overextend or rush my progress. And I learned that the hard way, with several trips to the ER with having small particles of food lodged in my throat and needed to be extracted. So basically what I did, I figured out what was the next step I needed, I got there and kept going until it was safe to have the tube taken out each time. Next slide. Due to the ORN and a combination of the ORN and increased dysphagia from an esophageal stricture, I had a permanent tube inserted in April of 2019. So now I get 95 to 100% of my daily calories and nutrition through the PEG tube. Basically, the only thing I eat orally is a little bit of yogurt in the morning and the occasional very thin soup. I have an glottis that does not function properly, so I'm at a high risk of aspiration pneumonia, and in fact, I've had 2 bouts of that. So my daily routine is 5 cans of isosource. I get monthly refills on my food and supplies, and every 6 months, I go to Emory Hospital and have the tube exchanged. Next slide, please. This is what I do, and this is what I've learned about having the permanent feeding tube inserted. Again, I hated that I needed the tube forever, but eventually learned to be thankful because it basically keeps me alive. I've come to be at peace with it, even as unnatural and as uncomfortable as it is from time to time. I have a little protected spot in the kitchen where I do my feedings and a routine for them so that I don't forget, I don't do them incorrectly, and I do them with as least amount of stress as possible. I also try to be as possible, as normal as possible at home about all this. I sometimes cook for my wife. I sit with her while she eats, so she's not eating alone. I enjoy the aromas of food. I lift the spoon whenever I can do that safely. And I tend a little vegetable garden. I cannot eat anything that I grow, but I have a lot of enjoyment about making things that Terry can use in her cooking and giving a lot of it away. I'm also a competitive chili cook. So I've been able to keep up with that despite not being able to taste any of my own chili. I've also learned to be open with others on what I am and am not comfortable with at public eating events. If I'm in a place where people are eating around me and I'm not comfortable, I simply excuse myself, go for a walk, and come back when the event is over. Most importantly, I ask others around me not to change their food selection and eating plans due to me. I would be really uncomfortable if they were to do that. So around the dinner table, everyone else is eating. At the dinner table when we have guests, everyone else is eating. I'm enjoying the company. I'm enjoying the aromas. And I simply just don't eat. I'm allowed to travel. While having the feeding tube, I have a letter for TSA that describes what I'm carrying and why, and I've not had any problems with that at airports. When I need to take a lot of food with me on the trip, sometimes I will ship it ahead to where I'm going and not have to worry about all that extra weight in my luggage. Mostly what I've learned about having a permanent feeding tube is attitude management. As Holly told you, a couple of years ago, I wrote a book about my 2 journeys in cancer world. And the final chapter in the book is called It Sure Beats the Alternative. And this was written almost right after I had my permanent tube installed. I've had a very difficult journey in cancer world, first as a patient and then as a survivor. But for all of my difficulties, for all of my struggles, I have a life that I enjoy. I enjoy my retirement. I love my wife. She enjoys her retirement. We do a lot of things together. We travel. We have a place up in the mountains that we enjoy on weekends every once in a while. I still get together with family and friends. And other than having this unnatural protuberance in my stomach, I live a full, happy, and enjoyable life, which obviously sure beats the alternative to not surviving a stage 4 cancer diagnosis. So I want to thank you for your attention and your attendance, and we'll turn it back over to Holly.
Thank you for that wonderful presentation and sharing your journey with us, Mike. Our next presenter is Barbara Ebersole. Barb is a speech pathologist specializing in head and neck cancer rehabilitation for the entirety of her 18-year career. Currently, she is the manager of the section of speech pathology and audiology at the University of Texas MD Anderson Cancer Center in Houston. In addition to leading a team of 16 speech pathologists and audiologists, she continues a clinical practice and is pursuing her PhD. Please welcome Barb Ebersole.
Thank you, Holly. I appreciate the introduction, and I'm really happy to be here talking with everyone about dysphagia in head and neck cancer. Next slide. So you're here today perhaps because you or someone you love is having trouble with dysphagia. Dysphagia is the medical term for difficulty swallowing and is a symptom of head and neck cancer or its treatment. How common it is depends on multiple factors, but most notably the kind of treatment you had. We see the lowest rate of dysphagia in people who were treated with surgery alone, followed closely by those who were treated with radiation alone. Whereas about half of patients who are treated with the combination of surgery and radiation, and almost 3/4 of patients undergoing concurrent chemoradiation will develop dysphagia. Next slide. Your tumor size and location are really the primary drivers of all the treatment-based factors that increase a person's risk for dysphagia. But another big factor is you, your age, your overall health, your access to rehab and other support services can all influence your functional swallowing outcomes at the end of treatment. Next slide. Surgical treatment at its essence is the taking away of parts, right? The functional deficit is a result of a defect. And the impact of that defect really depends on what the removed structures did. Rehabilitation of surgical defects or dysfunction related to surgery focuses generally on strengthening of remnant structures, so strengthening what was left behind, range of motion and scar stretching, and training for optimal adaptation to the new anatomy. And in this gentleman's case, in the bottom 2 pictures here, he had a neck dissection. And so he's going to have manual therapy to work on finding new channels for lymph fluid flow so that he doesn't get that accumulation of fluid in his neck or lymphedema. Next slide. So this is a view of the throat using an endoscope that's sort of positioned right above the soft palate. So that little kind of punching bag flapper, when you look in somebody's mouth, that's the entrance of your throat from your nose. And here we see the base of the tongue, which is that pillowy thing kind of in the front of the picture. Then the larynx, so which is sort of this, the epiglottis is this shoehorned shaped piece. And then we see the vocal folds and some structures of the larynx. And where that arrow is pointing, it's sort of tucked away. It's always closed except when you're swallowing. That's where the opening to your food pipe is, or your esophagus. So looking at this, you can sort of imagine if you were to swallow food or liquids, the target of your airway, which is below your vocal folds, is a lot bigger than the target that is the opening to your esophagus. So the throat has to go through a series of, movements to close up that larynx, to close the airway, move it up and forward, which kind of opens up that back area where the arrow is, and it kind of becomes almost like a funnel that then will allow the food and liquid to safely pass into the esophagus without getting into the airway. And we call that swallow safety, right? It prevents aspiration. And then you can notice too that there's these pockets in your throat, right? So there's a pocket under the curl of the epiglottis, that little shoehorn looking bit, and pockets down at the very bottom on each side of that arrow. When we swallow, food and liquid has to kind of move through and past those pockets cleanly and clearly in order for all of it to ultimately get into your stomach. And we call that swallow efficiency. And swallow efficiency is also important because it determines fundamentally our ability to meet our nutritional needs by mouth. Next slide. So when you undergo radiation, particularly radiation to both sides of the neck, we can see changes to the structures and function in the throat. During radiation treatment, so, in the early stages when you're actively getting treated, we tend to see swelling, mucositis, so sores and that painful swallowing, and an increase in mucus production. That phase will resolve, but over time, we can start to see different kinds of changes in your throat, namely fibrosis, which is essentially scarring. And that scarring leads to stiffness, so it reduces range of motion, it constricts blood flow, and can diminish our ability to sense what's happening in our throat. And then for a small percentage of patients far out from treatment, and we're talking about like 5%, maybe 12, up to 12% of people who survive 5, 10 plus years, they may experience more significant dysfunction, namely surrounding denervation, which is basically the muscles in the throat and the swallow mechanism, and even in your tongue, can become weak and atrophied because the nerves that innervate them stop working. Next slide. So you all in the audience don't need me to tell you what the signs and symptoms of dysphagia are, because I suspect that many of you experience at least some of them. In the left-hand column here are sort of the more common signs and symptoms of swallowing difficulty after treatment for head and neck cancer. And on the right side of the screen are the less common signs that often suggest more significant dysfunction. And at the bottom in red, these are really the two signs and symptoms that are often the primary driver of recommendation of a feeding tube. Next slide. It's important to know, though, that symptoms or lack of symptoms may not always be an accurate reflection of your actual swallowing function. And this is because, as I mentioned, radiation can lead to reduced sensation in your throat, especially over time. So as a result, your swallowing function isn't necessarily aligned to your experience. And because of this, we recommend surveillance swallowing testing, particularly, again, for patients who have had multimodality treatment or bilateral radiation to the neck. And we do it either through an X-ray swallowing test or an endoscope swallowing test. And this is really the most accurate way to identify your current function, and more importantly, any early dysfunction, because we like to get at that dysfunction as early as possible. Next slide. So when we treat dysphagia, we can approach it in a number of different ways. We can approach it proactively. So often we do this before treatment radiation even starts. So these are like preventative exercises to try to maintain as much swallow function during treatment as possible. But we can also treat your swallowing problem reactively. And this is, after a dysfunction is identified. And we can do this through approaches that restore function, through approaches that compensate for dysfunction, and approaches that palliate for symptoms or dysfunction. And then finally, we can approach it through a maintenance strategy, which again is maybe in survivorship, but with the goal of just maintaining the function that you have over time. Next slide. I'm not going to go over all the different treatment tools we have in our tool belt, so to speak, but suffice it to say that in the 18 years I've been doing this, we've really come a long way with having options and tools to help patients improve their swallowing function or manage their swallowing symptoms. So there are options out there that your speech pathologist can help you with. Next slide. So in the meantime, there are some things that you can start doing right now to help yourself and your swallow. Next slide. If you are actively in radiation treatment, we recommend that you eat all through radiation. We call this a use it or lose it strategy. Patients who have an entirely oral diet throughout their treatment have a significantly better diet, like they can eat more of a variety of foods 1 year after their treatment than patients who are dependent on a feeding tube, either partially, but even more so if they're dependent on it entirely. So at Anderson, we encourage most patients to try to take as much of their diet as they can orally, despite the pain, despite the changes in taste and the diminished appetite, to do it as a therapeutic strategy. Next slide. If you're in survivorship, eating is still exercise for you too. We encourage our survivors to resist the urge to wash down foods with liquids, and instead to push with an extra hard, fast swallow to really try to get that food down without the liquid. Think of it as like a chin up for your throat. It's good exercise. Next slide. And then swallowing exercises, whether you do them proactively before treatment, reactively after treatment, or as a maintenance strategy in survivorship, swallowing exercises are important, even if you're eating a fully oral diet. And the way that I think about it is that swallowing is like a team sport, right? So if you have a structure in your throat that's not working as good as other structures in your throat, the other structures are going to kind of pitch in and help so that you can get through your meal, right? And that's a good thing. It's good for eating. But we also want to isolate the muscles that aren't working well and really target them so that we're making sure they're being pushed through their full range of motion or against enough resistance to optimize their function. Next slide. And then lastly, don't ignore change. Swallowing decline can sometimes be so gradual, it's easy to sort of overlook it. Pay attention periodically and reflect on whether it's been getting harder to eat. And if it is, get evaluated. And if you've had multimodality treatment or bilateral radiation to your neck, also consider having your swallowing tested in a surveillance model. So at Anderson, we do instrumental swallowing tested pre-radiation, 3 to 6 months post-radiation, 18 to 24 months, and then at 5 years. Next slide. So I hope this was helpful. I want to thank you for being here today. And I wish you all peace and moments of levity as you navigate this journey towards your new normal. Thank you.
Thank you so much for that very informative presentation, Barb. Our last speaker is Debra Ruzensky. Debra has been an oncology dietitian for over 20 years, 12 of which have been at MD Anderson Cancer Center. She has experience working with patients in the radiation oncology setting, general chemotherapy, and has spent most of her practice in head and neck surgery and medical oncology. Working with patients with feeding tubes to achieve optimal nutrition is her passion. She is the wife of a lymphoma survivor, mother of 2, and grandmother. Please welcome Debra Ruzensky.
Hello, it is a pleasure to be with all of you today and to talk for a few minutes about tube feedings and challenges related to these. Next slide. So you all know with a diet that good nutrition is essential, and with a diagnosis of head and neck cancer, nutrition needs are even increased before you start any treatment. The demands for calories and protein are higher, and eating normally may not be enough to meet that demand. Swallowing difficulty or pain often occurs along with weight loss before diagnosis. Nutrition is important for post-treatment healing and recovery, which all can be delayed or impaired if those needs are not met. During treatment, nutrition impact symptoms occur that affect eating and drinking. Some of these can linger for months. There are side effects from chemotherapy, side effects from radiation. Swallowing can be compromised to the point that a feeding tube is needed for nutrition and hydration. And then post-treatment, there can be some long-term barriers to eating that Barbara talked about. If you're not familiar with the American Institute for Cancer Research, I highly recommend exploring this site, aicr.org. There's information for cancer survivorship and nutrition on this site that is the most updated evidence-based information. So if you're able to eat by mouth, there is a wealth of highly plant-based recipes on this site. It could be good for prevention for others in your family or friends. So before you go searching for information on Dr. Google, I do recommend you check out this one. Next slide. During and after treatment, the foods you're able to eat may change. Textures and flavors are more limited. The speech language pathologist will determine through a modified barium swallow study what is safe for you to eat to avoid aspiration. And then registered dietitians can provide the education for the type of diet based on the recommended type of diet from this study. So if someone is at high risk for aspiration and cannot swallow due to pain from surgery, radiation, feeding tubes can become the lifeline for nutrition and hydration. Sometimes a feeding tube is short-term, maybe just a couple of weeks after surgery or a month or less. For others, it may be needed for months, and for some people, it can be lifelong. Next slide. But let's look on the positive side of feeding tubes. You know, they can be used to bridge a gap that's missing from oral intake. If oral intake is still safe and still possible, but you're not able to meet 100% of your needs, the feeding tube can help make up the deficit. Feeding tubes can also make sure you're getting good hydration, which will help avoid trips to the emergency center or just to the infusion center for IV fluids. If you're not able to swallow medicines safely, feeding tubes can be a method for administering pills that can be crushed, mixed with water or liquid medications. Healing and recovering time after treatment can be decreased if a feeding tube is helping with nutrition and hydration. For those who require a feeding tube for long-term use, quality of life is enhanced because you're getting all of your essential nutrients that you can't get by eating orally. A feeding tube is not a sign of failure. Let me say that again. A feeding tube is not a sign of failure. Head and neck cancer treatment is one of the most challenging from a nutritional standpoint, and there are things even the most compliant patient cannot control. Next slide. So this is just an illustration of types of feeding tubes that are commonly used. The nasogastric tube is the one that Mike mentioned that he had for like a month and a half. These are really intended for short-term use. For most head and neck cancer patients, if they need a feeding tube, it's usually some type of gastric tube, which means it ends in the stomach. And for those who don't have a good functioning stomach or for other reasons that we can't feed into the stomach, it can be placed into the small intestine or in the jejunoscopy. Those are called J tubes. Next slide. These are some common tubes, gastric tubes that we use at MD Anderson and many other hospitals as well. The one on the top left is called a PFG tube, and it's placed by interventional radiology. It has a longer internal tube and a curled end. It is held in place by stitches on the abdomen. In the center picture, that is a PEG tube that's usually placed in surgery or by a gastrointestinal physician in the outpatient clinic. It does have a shorter internal tube, and it's held in place either by a balloon or, in this picture, a bumper inside of the stomach. The bottom left nasogastric tube, or NG tube, is the one that I mentioned that's used for short term, like a month or less. It's placed during surgery for a patient to heal and recover from surgery for a few weeks before they start eating by mouth. Sometimes it's placed in the head and neck clinic outpatient if someone during radiation needs a tube urgently because they aren't able to swallow safely, and it's kept in until we can get them scheduled for a PFG or a PEG tube. If you have a feeding tube for life or for long term, the PFG or PEG can be converted to a low profile tube or a Mickey button, and those are on the right. The one advantage of this one is there's nothing hanging on the outside of the abdomen until it's time to feed. Next slide. Now, what are some of the common concerns of feeding tubes? Well, there's external issues that can occur, and then there's internal ones. Externally, the skin of the tube site can become irritated, red, or even infected. If the tube is moving in and out, even just a couple of centimeters, the stoma or the hole can be too big for the tube, and a red, like donut-looking skin can form around the stoma. This is called granulation tissue, and it's usually not a concern unless it becomes painful or it starts to bleed. It is recommended to wash the area or the skin around the tube with just mild soap and water and to keep it dry. If you're overly aggressive with cleaning with peroxide or alcohol on a regular basis, the skin can become too dry, and then this redness and rash and granulation tissue can form. Also, applying an antibiotic ointment on a regular basis on the skin when it's not needed can result in these issues too. So if you think you're having an issue with the skin around your tube or granulation tissue starting to form, it's best to have a dietitian, a nurse, physician assistant, or a doctor address the concern before you start self-treating. Feeding tubes can also become clogged. Keeping the tube flushed with water after each feeding and after each medication can prevent this. Using a little more pressure with the syringe to flush the water often opens up the clog, or using a little bit of a push-pull with the plunger when you're pushing water, that often is successful. It is not recommended to flush your tube with Coke if you have a clog. The acid in the Coke can erode the tube, the interior part of the tube. So if you can't unclog it at home, come to the cancer center where you're treated or the nearest emergency center for help. And as with anything that's used regularly, parts can wear out or break. So be sure you have someone locally who can address these concerns, like your primary care doctor or a GI physician. Internally, there can also be concerns. Soreness or tightness under the skin or inside of the stomach where the tube enters may require that the bumper on the outside has to be loosened. If the tube is moving in and out too much, that granulation tissue can form. Sometimes tubes fall out unexpectedly, so the balloon deflates internally or the bumper fails for some reason and the tube can fall out. If that happens, go to your nearest emergency center to have it replaced and bring your tube with you. The internal opening of your stomach can close in just a few hours. Sometimes the stoma site leaks and the acid, the fluid from the stomach can irritate the skin. So if your tube is leaking while you're doing a feeding, that means the tube is too small for the stoma and it needs to be replaced with a larger one. You can keep some split gauze padding under the bumper to soak up the fluid to keep it dry, but the gauze needs to be replaced often. Wet skin around a feeding tube can harbor bacteria, so clean and dry is the goal. If you've been tolerating your tube feedings well, and then you start experiencing nausea or reflux or diarrhea with your feeding, like immediately or during the feeding, this could be a sign that the internal part of the tube has migrated into the small intestine. So that longer tube that I showed that was placed by interventional radiology had that curled end. Typically, that's the one that we have issues with if this happens. And to determine if it's in the wrong place when you're feeding, we need to do an x-ray. And then the stitches can be removed on the outside. It can be pulled back a little bit and restitched in place. Next slide. There are so many formula options now. To determine the one that's best for you, your registered dietitian can help. There are standard formulas out there, high fiber formulas, low fiber formulas, chosen depending on bowel function. There are formulas higher in calories than others, and that depends on how much volume a person can tolerate or how large their calorie needs might be. There are specialty formulas for people with special diet needs, for example, people with diabetes or people with renal disease. Usually for insurance to cover one of these specialty formulas, we have to show failure or intolerance to a standard formula. So for example, if someone is diabetic, we have to show consistently that their blood sugars are elevated on that formula before changing them to a diabetic formula for insurance to cover these. There are also many, many options out there now for plant-based formulas. Some are more difficult than others to get covered by insurance. It depends on how they're coded for billing purposes, but many patients prefer these because of their ingredients compared to the other standard formulas. Long-term tube feeders might also try blending foods at home and putting through the tube with that large 60 milliliter syringe. There are several sites online with recipes. Your dietitian can help with some recipes for this. Just kind of caution you though that you should be real careful with safe food handling and cooking temperatures to the proper temperatures when you cook these foods and blend them. For success with this, the tube typically needs to be a 20 French size or larger. The smaller tubes tend to clog. Next slide. Insurance plans vary greatly as far as tube feeding coverage. So when I'm asked, is this going to be covered? You know, the best answer comes from your insurance company by calling to see what your plan will allow. Most private or other insurances will typically follow what Medicare guidelines are. Medicare requires that the tube feeding is your total source of nutrition needs, at least 75% or more of your calories, and medical documentation that there's a malfunction of the GI tract. For example, a good note from the speech language pathologist showing that you cannot swallow safely. And then the length of need has to be what Medicare calls permanent, is greater than 90 days. Short-term tubes like the nasogastric tubes that are used for like a month or less than 90 days are never going to be covered by insurance, and patients will have to pay out of pocket for that. There are now some private plans, though, that have formula exclusion clauses, which means they'll pay for gravity bags and syringes and all the supplies, but they won't pay for the food, no matter what documentation we provide. Next slide. So it's really important that if you have a feeding tube that you have follow-up with your registered dietitian for tolerance and adequacy ongoing. We monitor to make sure weight is stable, or if someone needs to gain weight, are they getting enough calories and protein to do this? We always talk about bowel regularity. How are your bowel movements? We want to make sure that the formula is right for you. We talk about tube site care and concerns. Also, just like other prescriptions for medicines, tube feeding prescriptions expire. And so we have to renew those from time to time. For some people, it's every 6 months. If you're a long-term tube feeder, if you need it for life need, it can be renewed once a year. If you're not going to continue seeing physicians at your cancer center, you need to have a doctor locally who will be willing to sign that order once a year and get it renewed. So now I'll turn it back over to Holly.
Thank you so much, Deborah, for all of that great information and for the resources. Now we'd like to turn it over to the audience for questions. We have a quick poll for everyone to participate in so that we can better answer your questions, and we will have that loaded now.
First question goes out to Deborah. Question 1, does sugar feed cancer?
Wow, if I had a nickel for every time I got that question. So let's just talk for a couple minutes about that. There's a long version to that answer, but the short version is current research, which is ongoing, does not support that sugar causes cancer. Okay, it does not cause it. There are different forms of sugar out there, of course. There's carbohydrate foods that are complex carbohydrates, which have a lot of fiber, have a lot of B vitamins and a lot of good nutrition. We have carbohydrate foods that have a lot of added sugars, or we call them simple carbs, which don't really have any fiber. They're mostly sugar. They digest more quickly in your stomach and into your intestine. So the goal is to minimize those types of carbs in your diet because they're minimal nutrition. They're not really helpful other than packing on some calories, which could lead to weight gain. And obesity and overweight is actually a risk factor for over about 16 cancers. So that's one of the connections with sugar and cancer, is that it does lead to obesity. Glucose is the endpoint of digesting complex carbs and simple carbs, or the refined carbohydrates that have a lot of sugar. You get glucose from all of those foods, and we do need glucose. Our cells need glucose. That is the cell's energy source. Brain cells use a lot of glucose. The cells in your GI tract, so from your mouth all the way down, all the way to the other end, those cells turn over quickly, so they use a lot more glucose than cells that are just kind of sitting there, not dividing rapidly. So you can't really starve one type of cell without the other. So if there's active cancer cells in your body, whether you know it or not, avoiding all carbohydrates will not starve those cells and only feed our good cells. So it doesn't work that way. Every cell that is looking for some glucose will get it from our diet when we eat those foods. Now, what if you eliminate every source of carbohydrate in your diet? So you're getting nothing, no complex good carbs, no simple carbs. There's such a demand for it in our body, especially those brain cells, that your body will start breaking down protein and some fat, and then it gets converted into glucose. So we don't really want to use our muscle for energy. We want to eat the protein to maintain our muscle mass, but we want to eat those complex carbohydrates to fuel the cells. So when you hear that phrase, sugar feeds cancer, it's not exactly accurate. Another connection is when you eat a lot of sugary foods, that causes your pancreas to pump out a lot of extra insulin. Insulin has to get that sugar out of the bloodstream and into the cells. Insulin and other hormones are growth factors. And so if you have a lot of extra insulin floating around because of all that extra sugar you're eating, it can actually stimulate growth of the cells we don't want to grow. So that's really the connection with sugar and cancer. So focus on those complex carbohydrates, limit those simpler added sugars as much as you can.
Awesome. Thank you so much, Deborah. I know that question comes through clinic an awful lot, so thank you for clarifying for us. I want to loop back now to the polls. They have come in. So we've heard from you in the audience. Let me see here. So question number 1, have you had aspiration pneumonia? It looks like for the overwhelming majority of you, the answer is no. Almost 80% of you had not had an aspiration pneumonia. For the question related to feeding tubes, we have about 10% that have short-term feeding tubes, about 14% with long-term needs in feeding tubes. And again, the overwhelming majority, almost 76%, do not have a feeding tube. When it comes to restricting what you eat or drink, about 40% do not restrict anything that they eat. And again, about 10% or so have a feeding tube that they use. And for where you are in your survivorship journey, it looks like everybody's kind of right in the middle of the pack. 32% have a family member or caregiver in their journey. And then we're kind of split 3 ways: less than a year out from treatment, less than 5, or greater than 5 years out. So that makes up our crew today in watching this webinar. So thank you for filling those polls out. I'm going to jump into the next question. This question is for Barb. Barb, is there a core set of exercises that you recommend for all patients with a head and neck diagnosis?
I would say the short answer is no. In general, it sort of depends on whether we're talking about maintenance or prevention type program versus a restorative program or an exercise program that's aimed to try to improve diagnosed dysphagia or dysfunction. If we're talking about a maintenance program or a preventative program, like an exercise program that someone might do during their radiation treatment, then it is, yes, there is generally, there's like a prescribed program that can vary a little bit from institution to institution. But in general, it's sort of an exercise program that targets sort of the primary muscle functions during swallowing. So like a effortful swallow, Masako maneuver, Mendelssohn maneuver. And this is where sometimes there's institutional variation, like Shakir, chin tuck against resistance, Mendelssohn maneuver. Usually some mouth opening exercises. We at Anderson, we also do neck range of motion exercises. So for maintenance and prevention, yes, a standard program. If a person has a diagnosed dysphagia, the exercise program is targeted specific to their areas of dysfunction.
Perfect. Well said. Yes. It is difficult to always offer those out when we don't know the whole story, but yes, beautifully said. Next question comes in is actually for Mike. Mike, what is something you wish your medical team told you early on or earlier that may have helped your physical expectations or mental outlook?
At the very start, my wife Terry and I got a long list of possible side effects from the radiation and chemo treatments, and unfortunately, almost every one of those side effects happened. What they didn't tell me about at the time was osteoradial necrosis and an esophageal stricture. And those ended up being my two major and now lifelong side effects. And I can understand why they didn't mention those, because they're, first of all, very rare, and second of all, they are very serious. You know, it would be very easy for someone to get very, very frightened over hearing about what ORN is and what it might do. So, although my medical team was very honest, they were very conservative with the treatment for ORN leading up to the mandibular resection. And even though it eventually became inevitable, they waited long enough that I knew absolutely that it needed to happen.
Thank you for that. That's really insightful. Thank you. The next question comes in. It's for Barb. Barb, can radiation fibrosis be visually seen? And if so, is there a rating system?
Well, I would say the short answer for the first question would be no, but it's like a no in pencil. So there are oftentimes, you know, if you're wondering, like, can I see if I have radiation fibrosis, right? There are sometimes clues, right? So if your neck is really hard and really woody, you know, you touch it and it's like tap, 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 it's not soft. That's a clue that you might have some fibrosis going on, okay? If you're being seen by a clinical provider, say a speech pathologist, and they put a scope through your nose and we look at the mucosa inside your throat, kind of like that picture in my talk of looking down someone's throat, we can see fibrotic change that way. It's a little more visible in the mucosa, particularly if it's related to swallowing. As to a rating system, you know, my experience, at least if we're talking specifically about fibrosis, you know, fibrosis is on a continuum with something called lymphedema, which I'm sure many of you have heard about. And lymphedema there is a rating system to measure that. And my colleague, Holly, could tell you all about it because it's how she spends the overwhelming majority of her practice managing lymphedema and fibrosis. But fibrosis itself, like if we're talking about looking in someone's throat and seeing fibrotic change, I'm not aware of a rating system for that. Period.
Thank you, Barb. Yeah, those rating scales can be challenging, again, because it is on a continuum and it depends on what structure you're looking at. I know that in clinic, what we tend to use, CTCAE is the most global, but there are other adapted scales out there. The lymphedema fibrosis scale from Vanderbilt is also a nice one that we like to use as well. But yeah, it's hard to capture right when you're just looking at it. You have to palpate as well. The next question goes out to Debra. Debra, why are commercial formulas promoted over blended real food diets or blends of real food like Liquid Hope?
Oh, good question. So part of that has to do with insurance and how expensive those blended food type formulas can be compared to the other formulas. Hospitals all have their own formularies, which means this is what we have in our kitchen. This is what we use inpatient. And so those are going to be used while you're admitted, typically. The newer plant-based and blended food type formulas are coded differently. I don't know who decides what the B billing codes are for Medicare and for insurance, but if they're not coded the same as those standard formulas, patients get the bill. You know, where I work, we are willing to try anything the patient prefers as long as it really is a good formula for them, knowing that it might not be covered by insurance. And so we just have to put in an order for it and run it through and see what happens. But they all serve a purpose with calories and protein and vitamins and minerals. The whole blended products, like Liquid Hope, it doesn't work in some of the tubes. It's thick. So if you had a nasal tube or a smaller French size tube, it's really thick. And if you have to feed through a pump, Liquid Hope won't go through a pump. So there's different issues like that to think about. There's another product out there that's blended food that they have 5 or 6 different options, but you have to mix and match them so that you get all of your nutrition. So there's different reasons why. We're finding more and more, though, that these plant-based formulas are getting covered more and more, and we're using them a lot more. Just know the cost is more. Sometimes the insurance will pay for what a standard formula would cost. For example, if like Mike is on a product called IsoSource, let's say it's $2 a carton. And let's say the plant-based version of that is $4 a carton. His insurance might say, we'll pay $2 of it, you pay the other $2. So you have to look at all those things too. But just communicate with your team, whoever's ordering the formula, about the options that are out there and what you might want to try. If you're home blending, you still need supplies. You need gravity bags, you need syringes, you need all the products that go with how to get the food in your body. And many times, especially Medicare, you cannot order just supplies without a food. They won't pay for the supplies unless you put a formula in the order as well. So there's a lot of stipulations that are really controlled by those things, unfortunately.
Thank you. That really helps clarify. And then probably the final question, we've got about 3 minutes left for Mike. Mike, what advice would you give to patients that are just beginning their journey?
My best advice would be, besides the obvious, listen to your medical team, would be to have a plan, to manage the process, to know that you're not just a passenger on a bus that you have no control over. There are a lot of decisions that need to be made, and you can get good information about how to make those decisions as best as you can. And one of the things I did is I was very upfront and open with my friends, my family, my students, everyone. And I let anyone that wanted to help, no matter how little or how large it was. If you wanted to be on the team, you're on the team. And so in the book, I make it very clear, there is no I in cancer. And I took that very seriously and made my journey, the journey with a lot of other people on board.
Thank you, Mike. And actually, Mike, one final question in the last few seconds of this. Do you recommend joining a support group as a patient or as a caregiver?
I think that's a question that needs to be answered on a very personal level. I use Cancer Survivors Network quite a bit, and they were very, very helpful. I did not go to any in-person support groups. And eventually, as my side effects became more and more apparent, I found that my situation turned out to be more and more unique, and that I was in a little bit different boat than most other people.
Thank you for that, Mike. Okay, everybody, thank you for tuning in today. This was such a lovely group of speakers and great information. I'd like to thank all of our survivors and their caregivers for their attendance. And again, a special thank you to Barbara Ebersole, Debra Ruzensky, and Mike Metzler, as well as the Head and Neck Cancer Alliance and the American Head and Neck Society for their time in organizing and hosting this Survivor Symposium. Thank you, everyone.